So the idea is to discuss when to be aggressive with a particular lesion and what is actionable and what is worth an invasive procedure. And I'd like to start by asking the panelists one by one. I guess we can go from left to right first and then maybe from right to left. We'll start with Kelvin. I understand that overdiagnosis is a concern. It's really a public health concern, and it's about looking in the rearview mirror and understanding that that particular tumor didn't kill that particular patient because they died in a car accident or because they had a heart attack, and then we overtreated that patient because they were going to die from some other cause. So, and I don't mean to be facetious about that, but there's an element that we cannot act upon as physicians, and we look at a particular nodule that looks malignant, is behaving in a malignant fashion, and we can't really predict when we don't have a crystal ball to know what is the true overdiagnosis in a particular patient. So in clinical practice, this is a concern. So the question is, do you think this is a real problem, and where would you, or how big of a problem is it? What would you consider the true overdiagnosis rate in lung cancer screening? Calvin.
Very difficult question. I guess if you see a lesion and it is, you think it is cancer, or you biopsy and it shows it's cancer, it's very difficult to say, well, I think you're going to have a significant competing cause of death. Let's say it's a stage 1 cancer, and I expect the chances of you surviving the cancer after resection is conservatively 80%. Then I have to be quite sure that there is more than that chance of you dying from another cause. And you have to be pretty sick with that. You have to have end-stage heart failure, end-stage renal failure. And I think in practice, we're doing that already. I guess the question is, how do you make the treatment safer and safer so the competing cause of death have be so high that that is not worth doing surgery or treatment?
Maurizio.
So for me, as Kevin said, we don't have a crystal ball, but we do have some clinical feeling. I know it's difficult to standardize, but when you see a patient who is really in a bad shape and you see a pure GGO, you might anticipate that would be overtreatment, so overdiagnosis. We know from the literature data that overdiagnosis in lung cancer screening varies from 3% to 30% or more. You really can't tell who is going to be the one. But we should not forget as physicians that we do have a sensation of whether the patient is going to live longer than the time to progression or less than that. This is somewhat you can use. I understand it's difficult, it's vague, but this is my feeling, and this is how I behave.
Definitely public health specialists continue to suggest that overdiagnosis is one of the major obstacles to implementation of lung cancer screening. Regarding competing causes of death, what would you consider are more important? Is it age? Is it comorbidities? Is it functional status? Do you take this into account in a formal way, or do you have a general sense of what that patient is expected to face in the near future, and that's how you decide to intervene?
So as a radiation oncologist who only accepts patients through the tumor board, it depends on clinical context. If there's solid tumor and it's an indication for treatment, we would treat. The clinical context is, let's say the patient was admitted for heart failure or a pneumonia or exacerbation of COPD. We always say, why don't you wait till the patient comes back to the primary physician's first follow-up and fit enough, then we would treat. I should say that our practice is largely guided by the Mills study, so we wouldn't treat GGOs generally as a default position. So we looked it up once in the SEER database for 1 year survival after stereotactic radiotherapy, where I have the most experience with, and the Dutch National Cancer Registry. We look at the 1 year mortality. So if that was high, and you really wouldn't expect a small stage 1 to misbehave, so in SEER is about 3%, and in our national database is close to 2%, 1.72%. So I think that overdiagnosis, overtreatment in that context appears to be low.
And while I have you here, would you say that it's necessary to get a biopsy and a proven diagnosis before you do SBRT? And then I'll ask Juan Carlos, do you need a biopsy before you operate on a particular patient?
So we follow the ESMO guidelines, and I think the US guidelines are much the same. A biopsy is always preferred. Evaluation by MDT is always preferred, but you can treat, firstly, if the biopsy, attempted pathology was unsuccessful, the patient's at a very high risk, or the patient refuses it. And the way we work in our practice is we look at the percentage of patients operated on without pathology who turn out to have benign disease. So for our practice, we think it's about 3 to 5%, and the 5% is what I cite to patients. The Yorkshire CT screening study published that as well recently. That was about 3.8%. So you have that risk of treating patients for benign disease, but it's something you can take as part of a shared decision-making after going through the tumor board process.
Yeah, trying to answer the first question, we don't have to forget that we are in front of the highest, the cancer with the highest mortality around the world. So we are discussing about overdiagnosis, but I think that the action is justified. If you are the suspicion that you are in front of lung cancer, of course you have to follow the common sense and the clinical feeling that you have in front of your patients. Of course, if you have a patient with an 80-year-old higher morbidities, of course you have to follow. And trying to answer the second question, I think it's mandatory to have a good biopsy before any treatment. In my case, for example, I think it's not possible to go to the operating room if you don't have a confirmation about lung cancer or you have a malignant diagnosis. But I operate a lot of patients without diagnosis, more than 20%. So this is the real world. And I think we have to develop different techniques, talking about robotic bronchoscopy, navigation bronchoscopy. We have other methods that we have to improve or implement in this kind of hospitals. Of course, if you talked before about the accreditation of lung cancer screening centers, one option is to indicate this kind of practice to be accredited or not. And I think the common sense is the answer of both questions.
Is it a common practice to get a diagnosis before surgery or before SBRT?
Well, I think that here in Gdańsk, we also try to get biopsies as much as possible, both for SBRT, but also for surgical cases. The problem that we have is with GGOs with minimally solid components, where we know that the biopsies cannot be accurate, and if we have like 2, 3, 4 scans showing us that how the nodule grew, we may decide to go to straight surgery, and eventually also, because we know that the rate of solid component presenting as minimally invasive or invasive adenocarcinomas is virtually very high. So in these cases, I don't know, Witold, if you agree with me, we often make the decision to go straight to surgery. Another question, should we really do workup the same as for solid stage 1 adenocarcinomas, in which we always want to have a PET CT scan? In these situations, we tend, especially if there are some cues for PET scanning, if this is more than, let's say, 3-4 weeks of waiting, which occasionally happens in the end of the year, all PET scanners are, for this or that reason, closed for maintenance, and we don't fully know whether that's our colleagues' holidays or it's really happening. But if something like that's happening, we prefer just to go straight to surgery, because we know that the risk, and that was also nicely shown during presentations today, the risk of mediastinal invasion, mediastinal dissemination, and distant dissemination is pretty small. It's virtually absent. So these are our problems.
Well, we definitely go all the time with biopsy in solid lesions. When cancer is suspected, of course, we go with, we try to do in all cases the biopsy. And the different situation is with non-solid lesions, especially the GGO lesions that are that we surveyed, and then it grows, and the component becomes clear. Then we should decide, and we're deciding about go straight to the surgery. We should do that. Sometimes it happens that we have this component, we do the biopsy, and we are not in this component, we have AIS, but then it grows still, then we operate, and we have adenocarcinoma. So if it happens, I think that we can resign from the biopsy when we had non-solid lesions or pure ground glass opacity that starting to have the component. Then no, only this, plus maybe in this case maybe PET scan can be supportive.
So many years ago, at an I-ELCAP meeting, Dr. Bauer in Delaware brought up this point that when he started using the I-ELCAP protocol, and we've heard this from Dr. Yip, his resection rate for benign lesions actually went down. And he was called into the administration, and there's this concern, right, that lung cancer screening, if it's implemented, is going to cause all these unnecessary procedures. But in reality, when you apply a protocol, as what happened with Dr. Bauer, he was called into the administration because he was operating less. And his response to the administration was, well, but if you look at what I'm operating on, there are more cancers now. So I'm doing fewer resections of benign nodules. And so potentially using a protocol is a way forward. What do you consider in your practice an acceptable benign rate of resection of a lung nodule?
Well, I can tell you that we summarized lately the results of our pilot study. And we had here, we made the unnecessary resection rate was still 14%. That's what we want to achieve. This is definitely below 10%. The, absolutely perfect is what Mauricio showed us, 2.3, 2.5. It's, I would have that, but the reality we are doing lung cancer screening for a long time, so we should have under 10%, but we still have 14%.
Our data in Pamplona is about 10. I would like to know what the rest of the panelists think is acceptable.
For me, acceptable, it's less than 10%. It's the rate that we have actually in our department.
I mean, this is a balance, isn't it? You want to operate on every single cancer without missing a cancer, and you can't do that. If you only operate on 20% of the cancer and they're all cancers, you'll have 100% positive rate, but a zero benign resection rate. But what about the other 95% you've missed? So I think that's actually two different questions. Whether one, are you managed to avoid your benign resection, and are you operating on everyone who needs a resection without compromising? We have a benign resection rate of 7%. It was actually 15% before we had robotic bronchoscopy, and it's now down to 7, but it's still 7 because there are nodules which are highly suspicious, but you don't get a tissue diagnosis, but everything tells you to biopsy it. Yeah.
And it's an interesting question. What of those supposedly benign resected nodules, which ones do you think, or how many of them do you think are actually actionable? Meaning, for example, a tuberculosis. That's an actionable diagnosis. If you see a lung nodule and it turns out to be tuberculosis, this is relevant not only for the patient, for their families, even for public health, right? So you could argue those are not unnecessary resections. You need a diagnosis sometimes, and that diagnosis may be benign, but it may be actionable. What do you think is the percentage of those benign resections that are truly actionable and that you needed to know what that benign diagnosis was?
It's a pretty low percentage, I think, but again, it varies from center to center to decide what is actionable. For example, you could discuss whether asymptomatic aspergilloma is actionable or not.
That's right.
Sometimes they don't need any treatment, but you resect it and it's aspergilloma, and then you say it was actionable. You wouldn't have done anything had you known. So what we do is we don't biopsy everything beforehand, before surgery, but we have some pre-specified criteria to go to surgery without preoperative diagnosis. One is definitive proof of growth and a positive PET scan. So if you restrict to that, you see that the lesion was retrospectively visible and growing. You might question whether it is really necessary to go for a percutaneous biopsy. The other one is mixed ground glass lesions. They are fairly typical. You may want to do a PET scan to exclude that the lesion has lymph node metastasis that you never find. There are no. But this is another criterion, especially if you see some progression. Otherwise, okay, you try to get a biopsy. And what is mostly misleading is when the patient has a prior malignancy. They have a new nodule, you don't know what it is, but the oncologist wants to have a diagnosis. And you get, say, 10-15% false negative or inconclusive biopsy rate, so you resect. This is the typical situation where you end up doing benign resection.
Juan Carlos.
In Spain, for example, you know, we have year by year, the number of patients with tuberculosis is higher. And I think the number of patients with benign lesions that we operate is lower year by year. I think we are applying better protocols, we are applying better techniques to diagnose. And when you go to the operating room or to do a biopsy or SBRT, I think that it's justified because the probability to have a cancer, it's higher. And if you have a benign lesion, then, well, in my opinion, it was justified. And that's all. In other cases, okay, you have a lesion in the colon, for example, and you operate and it's benign, and we are not discussing about the colorectal cancer screening. So, in my opinion, it's we have to develop better protocols, we have to apply the correct techniques to have the better diagnosis before the treatment. But if finally you have a benign lesion, I think it's not, because we are applying, in case of surgery, we are applying minimal invasive surgery, we are resecting the lower quantity of parenchyma that as we can. So I think it's we are developing techniques trying not to increase the morbidity related to the treatment.
I should add that in our practice, if we had somebody who had come from Asia for many years, lived many years in Asia and came, we'd be, according to the guidelines, reluctant to treat without tissue, mainly because of the tuberculosis situation. That's the Asian practice guidelines. I'm not sure who wrote it. They suggested not because incidence of opportunistic infections are high, and our Western prediction models don't work because many of the females who develop lung cancer are non-smokers. So it's a total different ballgame, and I think for the global context, stereotactic radiotherapy without pathology is something I'd be very reluctant to do in an Asian context.
But I want to stress one thing. If you ask somebody, anybody, any one of us, do you prefer to do biopsy or do you go to the surgery with biopsy or without, depends very much on what radiologists do you have. If you have very precise radiologists, then you go to surgery always after biopsy. If not, then you decide very often not to do biopsy because it's useless sometimes.
I just want to say that the example of TB is not a good one. So TB can be diagnosed before surgery. A specific benign, haematomas, TB, granulomatous inflammation should be diagnosed before. And the benign resection should belong to the group that, such as inflammation, fibrosis, which could both be present in benign and malignant diagnosis, because those are the non-specific. That doesn't tell you whether it's benign, and then it will depend on your hunch whether there's something malignant hiding in it. But if you suspect it might be TB, biopsy it, because you can get the diagnosis. You don't need to put your patients through a treatment if it is TB. It shouldn't. Well, I try to avoid it.
I have to say it's quite attractive to see the kind of trade-off equilibrium that Ravenna has shown us. I mean, you have a clear pictures of malignancy, say tumor growth, certain characteristics, radiological characteristics, PET scan clearly positive. In such situations, you oftentimes think, and especially in a patient with comorbidities for whom biopsy may be tricky, you often think, how much really do you need this biopsy? What is the potential benefit versus harm? And that's something we could perhaps be helped with some AI tools, because the potential problems may be significant in some patients. I don't know if any of you would like to elaborate on that.
I did think, because we hear so much in discussion about using AI to evaluate a nodule growth and so on, and I'm sitting there, I'm just going to biopsy it, so actually it doesn't help me. But what I need from the AI is tell me in the lesion, they're treating the lesion like it's one homogeneous thing, and it's either benign or not. When I'm actually interested in which bit I need to biopsy with the highest chance of getting an accurate malignant diagnosis. You know, those lesions, the ground glass, which bit is the most suspicious bit? Because if you think you have the tool to biopsy it very safely, then actually the tool should assist that.
PET scan, you have PET scan, and then you have...
Well, still the PET scan is too crude. I think we need more clever voxel interpretation.
But imagine an AI algorithm will tell you exactly this nodule having these characteristics has 92% malignancy probability. Would you go for biopsy or would you go straight to surgery?
I think if it's over 90, then you probably would believe your biopsy less, so you would go straight for surgery. But over 90.
Agree with that,
yeah.
Yes.
Mauricio has a comment, yeah.
Regarding PET scan, for subsolid lesions, you don't need a PET scan to make a diagnosis, but it helps you understand whether the lesion is progressing. If it becomes PET positive over time, you can anticipate it's becoming invasive. This is a criterion that we follow with good satisfaction. Yes, we're happy about that. Yeah.
So one question for the panel. There's a growing tendency, or at least in research, and certainly it looks like it's coming our way. Immunotherapy is neoadjuvant treatment for lung cancer. Do you think that's going to change your routine clinical practice in terms of biopsying, yes, always, or no?
In my opinion, yes. Completely agree with the change that we live we are going to live in the near future. I think in the 10th edition of the TNM, I hope that we have more information about biomarkers, for example, and I think it's a game changer in how to treat the lung cancer, because we are treating just following the anatomical criteria, and I think for me it's not enough to treat correctly lung cancer. In early stage, of course, we have to add the biomarker information to know how to treat these patients, because we don't have to forget that 40% of patients had a recurrence after 3 years. So I think it's important to keep in mind that something has to change. And if we have to detect more cancers, we have to improve the quality in diagnosis and in treatment.
I'd like to ask my co-moderator, what do you think about neoadjuvant immunotherapy, and does that force our hands, so to speak, to diagnose before resection?
Yes, I think we're going in that direction. When you look at the current guidelines, it's not there for stage 1 yet. I'm going to speak about that tomorrow. But when you look at the results, you can imagine that the results that you get for instance, a 4 centimeter nodule or a 4 centimeter lesion, I must say, where it's currently the cutoff for adjuvant, at least, immunotherapy, or when you look at those results, then you can imagine that you can extrapolate them also for a 2 to 3 centimeter or a 3 to 4 centimeter nodule. So it's very likely, I guess, that we will go into that direction in the near future. Another thing we are now working on is, but it's very preliminary, but it's injection of immunotherapy intratumoral. In small tumors. It's been beneficial with promising effects in melanoma patients and thyroid cancer patients. So that is also something that we now do 7 to 14 days prior to surgery. And of course, this is very preliminary, like phase 1-2 research, but when it goes into that direction, pre-treatment diagnosis becomes even more important also because especially for these cases, you want to rule out specific mutations. So there you definitely need your tissue.
Go ahead.
I would say I would answer this question yes and no, because for very early lesions, the need for systemic therapies has to be proven. All the clinical trials with neoadjuvant are not in stage 1, are in stage 2 and 3 and stage 1Bs eventually. So, typically screening detected cancers, they would have so high rate of cure that potential benefits from adding systemic therapies may not be so obvious. And now we have a number of clinical trials, especially with high-risk stage 1s treated with SBRT, trying to look at, like Pacific-4, whether adjuvant immunotherapy does change the outcomes of these patients. Neoadjuvant, of course, if we go for surgery and it's a high risk of dissemination defined in this or that way, yes. But again, with targetable mutations, you would like to know that. But in stage 1, early stage 1, I'm not sure if we have enough evidence to say we definitely need it.
I guess you're asking, do we want the biopsy after neoadjuvant? Is that your question?
No, before too.
I don't think.
If there's a role in the future for neoadjuvant immunotherapy in stage 1.
Oh, I see.
Does that force our hand in terms of getting a diagnosis? You're not going to give neoadjuvant therapy to tuberculosis, right? So,
yeah, I agree.
Hopefully.
I agree. And the oncologist will want to know the markers to know which agent to give as neoadjuvant. But I think the more important question for us as a surgeon is there pathological complete response? To make the decision whether, because at the moment, you're doing all this big, horrendous, heroic surgery for no tumor. And the biggest question is, when is the imaging good enough to tell us there is no viable tumor so that we can make a clinically important and relevant decision of, you don't need surgery, we'll just observe you?
We have no marker and we will not have in the near future. But the question was actually to Rafał, who is involved in a lot of clinical trials. The question that Luis asked us, that was the question if we have in the near future any trials that started and maybe will produce the results that will
answer that question.
Well, we have them. We have the trials with stage T2 and 0s treated with SBRT to show whether adjuvant immunotherapy, depending on PD-L1 status, changes outcomes of patients. A huge trial, over 600 patients. Looking forward to the readout in the very near future. So that is some potential benefit. And also oncogene-driven cancers, And we know it's a different biology. EGFR positive cancers, even if very small, they can be much more aggressive than we typically think, whether that's lack of presentation on PET scans of dissemination or any other reason. So we'll probably learn a lot there. For the moment, in very early stage 1, I don't think there is a need for systemic treatments, but this may change.
So many years ago, when I started with navigation, this was 20 years ago, the idea was that you could intervene, diagnose, and treat in one procedure. And this seemed very appealing, but never turned to be the case. Although, I guess, Kelvin, this is a question for you. Do you think that's ever going to happen? That we can do a procedure that's minimally invasive, diagnose the tumor, and treat it all in one procedure, and not have to send that individual for a surgery or SBRT or whatever it is that we're going to do to them?
As a surgeon, I regrettably say, yes, it's going to happen in the next 10 years. I'm going to talk about this tomorrow.
Hasn't happened in 20 years.
The reason is...
You're optimistic.
The reason is placing... The navigation is very imprecise. And so the ability for navigation to place a thermal catheter at the tumor to securely burn it was not available until the robot arrived. And so, but now it is very possible and very easy for people to do it. And you can see, because people believe in the system more, the volume of people doing peripheral bronchoscopy biopsy has exploded with the arrival of the robot, whereas previously very few centers actually buy the navigation bronchoscopy or believe it to use it regularly.
Juan Carlos, you had a comment. Yeah.
I was thinking about the possibility if some patients we decide to treat by ablation, for example, another rate to SBRT, and the other part we decide to start with induction therapy. We have to be careful because the patients that we can lose if we decide to start with induction therapy. I have to pay my house. I have to operate. I need money. So I think we have to think about the future and how to treat, how to decide the best decision in each case. I think we have to individualize the final decision. And I think it's difficult to homogenize and to decide just thinking about the stage or the size of the tumor, or I think we need more data to improve the protocols to follow.
Yeah, I totally agree. And in that case, to follow up, it's more like a side route. What do you think of like shared-based decision-making? We know now current guidelines usually unoperable patients, they recommend operation as a first choice. Do you think we should also always follow that? Should we really like have a conversation with the patient about that? How do you do it in clinical practice?
I think it's crucial to visit the patient and to tell them the benefits or the potential harms that you have with the treatment. And I think it's the same for the radiotherapies or the ablation. And I think it's crucial. In my practice, for example, I prefer to visit the patients. If we decide to start with induction therapy, I prefer to visit the patients before he or she starts with the treatment, because it's I think it's the communication with them and to tell all the pathway that she or he has to follow. I think it's important. For me, it's crucial. And to tell about the different ways that or the possibilities that you have during the entire treatment. I don't know if Mauricio or the rest of the panelists.
Maybe I can add that the shared decision-making, it's in guidelines, the UK, in legal ruling. And ESMO said that you can, of course, decline surgery as a patient who's operable if you don't accept the risks. So if you don't know what the risks are, you can reject it. Having said that, I think the British saber-tooth trial was very illustrative. So they took patients who had high risk for surgery, and they were counseled by a lung physician or an oncology nurse, and 80% didn't want to take part in the trial between surgery and saber. And I think 40% chose saber or 40% chose surgery and the rest the other treatment. And even after that, once they were randomized, they made choices again. So patients are capable of deciding. So in our routine practice of ours, we just say, surgeon will say, I can do a segment 6 resection, and I could say SEBA is also an option. And it's back to the treating pulmonologist.
So then in my outpatient room, I discuss with the patient, these are the options, that's how we do it. And we're pretty open on it also to the patient. And of course, when you have a young patient and you think like surgery might really be the best option, you talk to them a bit in that direction. So you have some influence there, but we really try to be open and let the patient decide as far as that's possible. But I'm not sure if that's everywhere the case.
But I should also add that we do give our opinion. Let's say the patient has quite extensive GGO and a solid lesion, and I would say, by the time I finish your radiation, it'll be a lobectomy, so why don't you do a proper lobectomy? That would be our advice. Of course, the patient rejected it, we would. If the patient had colon cancer, resected liver metastases, or something that looks like a speculated lung cancer, I might say, would it be not nice to have tissue and excision, anatomical excision, because then perhaps you're cured of your colon cancer, and you're probably cured of your lung cancer, as opposed to you wait for the next metastasis. So we try and give context in the tumor board decision-making so that the patient is capable, has the choice and can understand what the considerations are.
But I want to ask you, because now you said that you are talking to the patient, so pulmonologists are discussing with the patients what kind of treatment he will have. Is it routine in Holland?
Yes, in Holland it's routinely, we as a pulmonologist, so I'm more like a pulmonary oncologist, so I also prescribe the chemoimmunotherapy. So we do the whole, I think, more like the big routing of the patients. So first, after the MDT, I have the decision with, the conversation with the patient to make the decision on what kind of treatment. If they are really in doubt, that's maybe 1% of the cases, but then you plan an appointment both with the thoracic surgeon and the radiotherapist to hear from them directly the issues.
I'm just
but
asking
normally
because
after our conversation, I then refer, for instance, to the thoracic surgeon, and then they have their separate appointment for the intake and everything.
Okay.
So-
It differs in our reality, because if patient has stage 1 lung cancer, he comes always to surgeon first. If I have doubts, then he goes to Rafał, and Rafał talks to him, and as a second choice, like 3 days ago.
So in
So
the
you
context of screening, what would you prefer? A rule-out test or a rule-in test? If you had the perfect test to help you decide whether to be invasive, would you prefer a rule-out or a rule-in? Sensitivity or specificity?
You mean, would I rather miss a few cancers or overtreat?
That's right.
I don't think we're operating enough. And the reason why I say that is there are two pieces of evidence. One is in the UK, you can see each area's total number of lung cancer and the lung cancer resection. And we see that the places who have a high resection rate, in other words, they're pushing the resection to the high-risk patient, have an overall lung cancer mortality much less than the other areas. Which means, okay, your patient is high risk for surgery, 5% mortality instead of 1. But you operate on 100 of that, you still save 95 other ones that you haven't operated, you would otherwise have turned down. So you can save 5,000 patients by having an increase in surgical mortality for 100 patients. And the other piece of evidence is the region with the highest resection rate looked at what happened to the patients who were then turned down for surgery. So they're already pushing the limit to the highest. And they found that half of those patients actually died of lung cancer, not a competing cause. So I'd rather operate a little bit in excess because I believe the surgical risks are not that high and not miss anyone with cancer. A long way around to answer that.
I would still have a look if they have very modern radiation oncology services in these centers as well.
Can I ask if there are medical students or trainees in the audience? Are there any? Yeah? Okay. This is a message for you. It's not never black and white. It's a scale of grays. And what is high or too high risk or good or very good result is sometimes a personal opinion, as we have just heard. You can also tell patients about percentages of success and risk, 1%, 5%, but is 5% mortality high or low for you? So it's not really a shared decision-making, it's a steered decision-making that you are advocating.
HI beats AI in that respect.
Yeah, so remember, you can know the statistics very well and tell the patients, most of them will not understand and they will ask, what would you do, doctor?
I think it's some nice academic data available to sort of answer the question. The US data is published by Said in CHEST. What they showed is as the percentage of facilities with SABR increased, and as the volume of SABR increased, the surgical mortality decreased. So there's also UK data from Scotland, there's Dutch data, and there's data from Canada, I think it's Ontario. So if you give the surgical team the feeling that they're the only curative treatment, then mortality may be high because borderline patients are not informed of the alternative. So we have four of these publications which say it's a win-win situation. And the key point is the percentage of stage 1s who are untreated. So it was 9% in the Netherlands in 2016. It was 25% in England, where stable access is. I think screening, the Yorkshire trial showed that a third of the patients who participated in screening finally went to SABR, and those patients had actually more non-cancer related mortality. So it's like having a package for every patient, depending on their fitness, MDO assessment, and preferences.
Absolutely. And do you, and this is the final question, and we'll open it up to the audience in case there's questions there for the panel. Do you, in the context of screening where you expect potentially second and third primaries along the life of that particular patient, do you take that into account as compared to an incidental lung nodule that shows up and is a cancer and you operate on them? Do you treat those individuals differently?
Yeah, I think, in my opinion, something to keep in mind in the era of sublobar resection, for example. I think in this context it's crucial to indicate this kind of resections because maybe in the follow-up it appears another second malignancy tumor or third malignancy tumor. So I think it's now we have enough data to defend that a sublobar resection it's a good option in this kind of patients. So I think but we have to create the correct trial to know the benefits about functional benefits in this kind of patients, because you know the Jacob and the American trial, they weren't designed to analyze the benefits in functional and respiratory function. They only analyze the oncological benefits. So we have to design a correct trial to defend this idea, in my opinion.
Maurizio, you had a comment?
Yeah, well, we are seeking to obtain the maximum benefit with a minimal necessary sacrifice of function. So, yeah, I mean, you would treat differently if you expect this patient to have more cancers. Typical example, patient with multiple GGOs, one of which is progressing. You don't resect them all, do you?
Right. Well, sometimes, if it's in the same lung and it's there and it's peripheral, you take one out and then you do that, right? But
so for screening detected cancers, we usually treat them in pretty much the same way as conventionally detected. Taking into account the size is typically less than clinically detected cancers, which has implications. But the change in our minds when we did the pilot studies was that we are triggering a special pathway for these patients, which will be followed up then for years. and will show up with multiple primaries. Second one, third one, fourth one, and we should keep in mind that pulmonary function, especially in this way of thinking, is extremely important for these patients. So especially in the sublobar times, be as little invasive as possible, to keep in mind that respiratory function still has a role in terms of minimizing competing risks and making sure that you will be able to take care of this patient in 6 years from now when he will show up with another lesion.
Any questions in the audience for the panel? David?
Well, it's something I wanted to kind of maybe a comment, but I'm interested to hear what you think afterwards. It's in response to something you said earlier. We were on this whole overdiagnosis topic, and you said that sometimes overdiagnosis is not really clinically meaningful, and I like that you used the word clinically. And the reason I say this is because overdiagnosis is not a clinical concept. Right. It was nothing in clinical, there's nothing like it in clinical medicine. Its definition implies that cancer is not cancer unless you die from it. Nothing in medicine is defined that way. You don't define anything by saying you must die from it in order to be cancer, otherwise you're overdiagnosed. The concept came out from epidemiologists, and because it has the word overdiagnosis in it, people mistakenly think this is a clinical concept. It is not. If you have advanced small cell carcinoma, you can still be overdiagnosed. And I've had this conversation with senior statisticians at the NCI, and they argue that that's overdiagnosis. You die, it doesn't matter if it's stage 3, stage 4. And so it's not a clinical concept. And until we kind of get away from that, I personally really advocate that we redefine overdiagnosis, because what we talked about on stage here was slow growing. Everybody starts thinking it's indolent cancer and whatnot, and that's where the challenge is. So I was kind of pointing out that I appreciate your saying it's not clinically meaningful, and it really never was meant to be.
I agree, and it definitely has public health implications, meaning if you take somebody who comes to the doctor with a finding, then you have to act. But it's true that we're offering screening to individuals who are asymptomatic. So theoretically, if we're going to detect something that is not going to kill them and put them through the ringer, so to speak. Remember a patient I had who had a chest x-ray done by a cardiologist, found a lung nodule, was 95 years old, died in his sleep. We did navigation, we diagnosed the adenocarcinoma. We were debating what are we going to do with this man, and he died in his sleep. So I understand that is a public health concern, that we're offering something to somebody who's asymptomatic, therefore is not coming to us with a symptom that we need to act on. So the idea of getting invasive on somebody who was asymptomatic and healthy, so to speak, is definitely a concern, but I agree with you completely. It's not a clinical, if you see a lung cancer, you act upon that. I don't know anybody who says, oh, I know that's a lung cancer and I'm just going to sit on it, with the exception of pure GGOs maybe, that you're willing to wait and see, but that keeps you up at night, right? I always tell, nobody complains about getting a lung cancer taken out. And what keeps you up at night is following a nodule and seeing it grow and not knowing when, as was mentioned by Dr. Chen, when do you act? When in that progression, right?
If I may add something, what keeps you awake at night is when the patient dies after surgery. That is definitely...
That's right. Yeah, I have the luxury of not doing the surgery. So when somebody goes to surgery, I tell my students this all the time. I only have one patient in my entire life who had a benign nodule resected and complained endlessly about sending them to surgery. The rest, they're not many, but it's about 10% at our center. They never complain. They're so happy that it wasn't a lung cancer that they will not complain to you. So the rule out is for them, worth the hassle of what is becoming, as Juan Carlos said, less and less aggressive surgeries and better tolerated and so on, yeah.